Okay, Doc, we can go ahead and start whenever you're ready.
All right, sounds good. So good morning, everybody, and welcome to today's lecture. My name is Jamil Alfara. I'm a board certified maternal fetal medicine specialist and OBGYN as well. So one of my biggest passions is teaching and making sure that I help anybody that needs any kind of education in our hospital, in our program. The rumors are if there's a rock over there that's willing to learn, Jamil's willing to teach, right? So like I said, I've been teaching now for over 20 years, which doesn't seem, I don't know where those 20 years went. So before I actually go into today's lecture, I'd kind of like to know what your goal is of taking this course so that we can tailor this wonderful course towards your needs. So if you can just put in the chat just a quick, what is your goal? And are you a resident attending? Are you looking to freshen up, or are you preparing for the upcoming board exam that is happening at the end of June? So if you can just type in, in the chat box. And if you don't want to at this point in time, we'll move on and do this at a later point. Okay, so Dennis, you're looking here to get the CMA, and both are reviewing. So nobody's going in for an exam, correct? Anybody attending the, okay. All right, well then let's have fun, okay? Because then this becomes a dialogue, a discussion, a back and forth. What do you guys do? What is the most recent and stuff? So we're going to start with recurrent pregnancy loss, and then after that, we're going to move on and talk about IUFD, and then the second hour is going to be about twins, and then we'll finish my 2 hours for today by talking about breech presentation. Okay, so again, the lecture is consistent with all of the American College of Obstetrics and Gynecology guidelines, practice bulletins, committee opinions, and the Society of Maternal Fetal Medicine guidelines. I do not have any disclosures at this point in time. Unfortunately, I wish I did. So what is pregnancy loss, right? It is defined as a pregnancy that is no longer viable. And we've got to be sure that it is not going to be viable in the future, right? So not seeing a fetal heartbeat at one time does not mean that this pregnancy is not going to continue and become viable itself. On the flip side, seeing a heartbeat that goes away, right, is confirmation that this no longer is a viable pregnancy. So what does it mean? It means it's either an empty gestational sac or a gestational sac containing a crown rump or an embryo or a fetus without cardiac activity in a point where we are supposed to see fetal cardiac activity. And when we call it early, it's because it happens in the first trimester. Now, interchangeably, people have said miscarriage, termination, abortion, early pregnancy loss. There really isn't a lot of distinctions. However, in the general society, most people consider the term abortion as willing and the term miscarriage as spontaneous. But that's not necessarily what everybody does and uses. Okay, so here's what you've got to do. A lot of times patients are going to miscarry. They're going to be traumatized. They're not going to be happy. And they're going to say, well, doc, what happened? What are the chances of this happening again? Can you please do a lot of investigations for me? So I think when you look at things like this, what really determines your etiology is basically guided initially by looking at the patient's history, seeing what risk factors she has and what could have potentially contributed to this. And then your other guidance is gestational age. How early did this happen? Did this happen after a heartbeat was there that went away? Did it happen at 16 weeks or so when the patient came asymptomatic and suddenly miscarried? Is that an insufficiency problem? Antiphospholipid syndrome? Is this happening multiple times, to indicate that potentially the parents are carriers of a genetic abnormality that may be passed that may cause the miscarriage, right? Now, though, if it's just a random question, what is the most likely cause of miscarriage? Then, okay, it is generally aneuploidy, right? And please feel free to type anything. Then if you're asked, right, what type of aneuploidy, do you know what type of aneuploidy is the most common? Okay, so it depends on how you look at it. But the most common aneuploidy is actually trisomies, right? But if you noticed here, our trisomies are all lumped into one category. So trisomies are a whole or group as a group, so including trisomy 16, trisomy 21. As a group, they are the most common cause of miscarriage. However, if we are to dissect this a little bit more, monosomy X is the most common individual aneuploidy that causes abortion. What does that mean? It means that trisomies as a whole, right? Okay, is more common than monosomy X. But then if we start splitting the trisomies, okay, monosomy X, right? If we start splitting the trisomies, then monosomy X is more common than trisomy 16, which is the most common trisomy responsible for early pregnancy loss. And then if the question, or if the paused question to you is, what is the most common trisomy that causes miscarriage that is compatible with life, then that becomes trisomy 21. Okay? So those are the most common causes. So when a patient comes and asks you what is the most common cause of miscarriage early on, you can say it's genetic, right? And thankfully, a lot of these aneuploidies are not usually, recurrent. Now, especially when we talk about trisomy 21, the risk, does go up as the age goes up. Now, if the loss happens a little bit later on, it happens after 10 weeks, and it also happens when you've had a heartbeat. Patient comes in and you're like, congratulations, you're 7 weeks pregnant. I see a heartbeat. And then let's say they come in at 12 weeks and there's no heartbeat. You've got to consider antiphospholipid syndrome, okay, as one of your etiologies. Now, we will go over antiphospholipid syndrome because I know it's a very important topic, but the gestational age here leads us, right? If you have one miscarriage after 10 weeks, that's enough for you to consider antiphospholipid syndrome and do workup for it. Now, somebody comes in at 16 weeks and they've had a painless loss. They say, I don't know, doc, I was sitting there, I had an increase in my discharges, and then suddenly I started bleeding, and she comes in and you examine her and she's dilated and the baby shortly delivers afterwards. Then you should be very suspicious of cervical insufficiency, right? All right, everybody's doing okay so far. It's a little bit tough because I can't, it's a little bit tough because I can't see you guys and I can't hear you. But please, I want to know that you guys are listening to me, enjoying what I'm saying. So type in your stuff in the chat box, okay? Now, so before when I started, I talked to Dennis and Angela, and they were doing this mainly for CME. But since then, we've had a couple of people that have joined in. I would like to know, is there anybody that is taking the June exam? If so, please put it in the chat, because what I will do is, we'll still do our lectures, but I will in intervals throw in potential, very high yield information for the exam. Anybody taking the exam, please put in the chat that you're taking the June exam. If not, then we will continue. All right. Sounds good. So what are some of the things that if you see in a patient's history, you are suspicious that this person is at an increased risk of miscarriages? A 40-year-old comes in, all right, versus a 21-year-old. Who do you think is more likely to get a miscarriage? Or who are you like, oh, this is a higher risk pregnancy? I'm going to say the 40-year-old. Now, believe it or not, if we just ask a general question and say, in which population is it more common to have trisomy 21? Is it the 40-year-olds or is it the 25-year-olds, right? It is actually more common to have trisomy 21 in the 25-year-old population, right? Now, I didn't say the pregnant population. I said the population in general, right? Because at 25, more patients are likely to be pregnant. And by sheer number of more people being pregnant, then the sheer number of Down syndrome is going to go up. However, if I say I have a 25-year-old and I have a 40-year-old, and the question is, who is more likely to have a Down syndrome baby and both of them are pregnant, then absolutely the 40-year-old. Okay. So what else? If you've got an anatomical abnormality in the uterus, that increases your chances of miscarriage. If the uterus is septate, right? If there's a leiomyoma. Now, Asherman syndrome is also an increased risk of miscarriage. But if I have somebody who had Asherman syndrome or had an endometrial ablation and they're pregnant, honestly, the first thing that goes through my mind is not miscarriage. And I'm sure those of you that are sitting in the audience are thinking the same thing. If I have Asherman syndrome, I've lost my endometrium, and I'm worried that the implantation is going to happen in the myometrium, and I am worried about invasive placentation. Of course, cervical insufficiency and LEAP or conization increase your chances of miscarriage, but it's also more likely going to be a second mid-trimester, right? Diabetes, okay? And the most important thing that we need to know is adverse outcomes in diabetes correlate with hemoglobin A1C, right? And it's not just the risk of miscarriage that goes up with diabetes, it's also the risk of congenital malformations. Antiphospholipid syndrome, hypothyroidism, tobacco use, alcohol, radiation, toxins. Also, don't forget that twins are at an increased risk of miscarriage or an auto-reduced twin and twin demise. Now, when we talk about the types of abortions, what are some of the types of miscarriages that we have, right? And how do we discern what they are? It is, first of all, right, the first prerequisite to any of these is at some point in time, you had something inside the uterus, right? And for it to be threatened, that something in the uterus had to have had a heartbeat at some point, had to be viable, right? So when you guys think of, threatened versus inevitable versus incomplete versus missed versus, septic abortion, for me, two things come to mind, right? When we do the ultrasound, do I see anything in the uterus and does it have a heartbeat? Now, I also think of, did the patient come and say that she thinks she passed tissue? And on my physical exam, right, on the physical exam, is that cervix open or closed? Correct? And then the other thing that is always going to be on the periphery is the patient stable, right? Because it really doesn't matter what's going on. If the patient is not stable, then you don't have time on your side and you've got to act generally quickly. All right, I want to volunteer to tell me if we draw a table and have all of these miscarriages next to each other, right? And we say which one of them has a cervix that is open, which one of them has passed tissue, and so forth. Anybody wants to type that in the chat box? All right, we'll give it a couple of seconds. If nobody types it in the chat box, I'll take care of it. All right. It's still early in the morning, right? Any of you are not on Eastern time? If you guys are not on Eastern time, that's even much more earlier than my time, right? Okay. Perfect. So Dennis, incomplete and complete have passed tissue, which means that threatened and inevitable have not, right? And then the inevitable and the incomplete, the cervix is open, right? And the complete and threatened, the cervix is closed, right? Now, missed is the pregnancy is still there. We should see a heartbeat. We anticipate seeing a heartbeat and we don't see one. Or we had a heartbeat and the heartbeat is lost. Septic, it can happen in any of these, but the biggest thing is it is associated with signs and symptoms of infection. All right, signs and symptoms of infection. So now, once we've gotten to the diagnosis, right? There you go, this is the table. Then we come to management, right? for a threatened miscarriage, even though they tell them to rest and avoid this and avoid that, the reality of the matter is a strong pregnancy is going to stay no matter what, right? And resting, doing all of that sort of stuff is not going to do anything. And if you've completed the process of abortion or miscarriage, then there isn't much further stuff to do for you, with the exception of if the patient's a candidate for ROGAM, to give them ROGAM and so forth, right? Now, what about DNC versus medical, right? What's going to make you choose DNC versus medical, right? And remember, this is not, I come in, I have a viable pregnancy and I want to terminate. This is somebody who is either inevitable or incomplete, right? So I've got two choices. Either I give medication or I do a DNC. And in general, what dictates your choice? There's always going to be patient desire, correct? What does she want? Then what else dictates what you decide? What are some of the other things that will dictate what you decide? How much is she bleeding, correct? Is this bleeding soaking multiple pads? Is the patient stable? And also, what laboratory findings do I have? Is her hemoglobin 12 or is her hemoglobin 5? I'm more inclined to do a medical management that I know will take time and potentially cause more bleeding if the patient is stable and her hemoglobin is fine. If patient's hemoglobin is 5, I'm very less inclined to go ahead and manage this patient medically, right? Especially if she's bleeding. Now, what else? Could a patient's religious preference or her choice of I don't take blood products also influence your choice? So for instance, if somebody comes in and says, I'm a Jehovah's Witness, right? Would that influence potentially your choice of management? I definitely know it would influence my choice of management, because if I know somebody comes in with an inevitable or an incomplete abortion and she doesn't take blood products and she's stable at this point in time and she's bleeding moderately, I'm not going to wait till she becomes unstable, gets to a point where I need to give her blood and she refuses, right? So those would be all things that would make me choose potentially to go through the route of doing medical versus surgical. All right. Now, the last thing you want to do is tell a patient that the pregnancy is not viable or it's a failed pregnancy incorrectly. Especially if this is somebody that comes in, she goes, Doc, this is an IVF pregnancy. I'm 37 years of age. This is probably my last chance of having a pregnancy, correct? So you've got to be absolutely sure. And thankfully, there's criteria there that you can use to help you make those decisions. There are criteria that are absolutely diagnostic of pregnancy failure, and there are criteria where it is suspicious but not diagnostic. And those of you that are like me and are a little bit have been doing this for a good number of years will remember that the crown rump length diameter has changed, right? Do you guys remember what the crown rump length was in the previous version of this? It was actually 5 millimeters. Then they found that this was not absolutely diagnostic of pregnancy failure. And there were some patients that had a crown rump length of 5 millimeters that afterwards ended up going to become, have a viable pregnancy. And actually the citing or the reasoning that they say why this happened is not truly because you can get a pregnancy after a crown rump of 5 millimeters. This is actually taking into account the variations of how a crown rump length is measured. Remember, we're millimeters, so if somebody just puts their caliper or their caliper choice is a little bit different, that can have a big impact, right? So a crown rump length of 7 millimeters, a sac diameter of more than 25 millimeters with no embryo. So it's not just a sac diameter of more than 25 millimeters, it has to have no embryo, right? Then if you have no heartbeat 2 weeks after you see a gestational sac, all right? And this is without a yolk sac, okay? So 7 millimeters and above with no heartbeat, we're done. sac diameter of 25 millimeters, no embryo, we're done. I see a gestational, I see no heartbeat, okay? So I see a gestational sac and I don't see a yolk sac. Can't say that this is a failed pregnancy. But if I bring this person after 2 weeks, right, and I don't see a heartbeat, then that's a failed pregnancy. Now, if there is a gestational sac and a yolk sac, then I don't wait for 2 weeks. I bring the patient back in 11 days. And at that point, if there is no heartbeat, then I have diagnosed pregnancy failure. So sometimes, and that's okay, you will not be able to tell the patient the answer straight away. You're going to say, I see some things that are not, I would prefer to see a little bit more of this pregnancy. However, I need to bring you, in 2 weeks or in 11 days, because time will tell me if this is going to be a good pregnancy or not. And please come back if you have bleeding, cramping, and so forth, and you give her all the precautions. Now, if your sac diameter is between 16 and 24 with no embryo, highly suspicious, but not diagnostic. No heartbeat 7 to 13 days after a scan showing a gestational sac with no yolk sac. So if you don't wait your full 14 days, you can't call it, but it becomes suspicious, right? I think all of us, if we see a gestational sac and 1 week later we don't see any progress, we're very, very suspicious. But if the patient says, Doc, how sure are you? You're going to say, well, I want to wait the whole 2 weeks. If I see no heartbeat 7 to 10 days after a scan showing a gestational sac with no yolk sac. So if you notice what they did here is the numbers. Here it's 14 days, and here it's 7 to 13 days. Here it's 11, and here it's 7 to 10 days, right? So in general, if you don't see any progress a week after your first ultrasound, not very reassuring. Okay, if you have no embryo 6 weeks or longer after the last menstrual period, if you see an empty amnion adjacent to the yolk sac with a visible embryo, that is very concerning too. Enlarged yolk sac more than 7 millimeters, right? And then a small gestational sac in relation to the size of the embryo, less than 5 millimeter difference between the mean sac diameter and the crown rump length. If you guys look at it, you should have a sac that looks much bigger than your embryo, right? So it says if the difference is less than 5 millimeters, these are all signs and symptoms and suspicious that your pregnancy is not going to continue. All right, everybody's good and okay. Any questions so far? Everybody's good and okay, and any questions so far? All right, are we enjoying the lecture? See, I loved it more when we could chit chat and talk and interact, right? But we're still gonna have fun, especially if you've got our coffee in hand. And I bet, even though I can't see you, raise your hand if you've got a coffee with you. All right, I bet all of us have coffee, right? You can't graduate medical school and residency without being a coffee addict, right? And as you can see, I actually am one step worse than a lot of other people. I've got my coffee machine maker in my office. All right, sounds good. Okay, perfect. So we talked about the management, okay, of missed abortion and so forth. Now, remember, there is still role for conservative management, but it really is not very effective. And you can offer it to the patient. But it's not usually the route that most people go. But it is an option if the patient wants it. You counsel them appropriately, and they're less than 8 weeks, you can offer them conservative management. Now, factors to consider: woman's desire to continue the pregnancy, and how certain does somebody want to be before they go through the termination, and how anxious is the patient, and what are the consequences of waiting for intervention, which is kind of what we alluded to in the last couple of slides as well. Now, there are contraindications to conservative management. If somebody is showing an infection or signs of infection, is that somebody that is a good candidate for conservative or medical management? Absolutely not, right? Hemorrhage, no. Severe anemia, which we talked about. Bleeding disorders, if somebody is known to have von Willebrand's and all of that sort of stuff, not a good candidate. Now, I also added to this Jehovah's Witness. You've got to talk to them very carefully. And I'm not targeting Jehovah's Witnesses, but they do not accept blood products. So you've got to be very careful in their counseling. a patient that is very anxious or is afraid or lives very far away from the hospital. So you've got to use your common sense. If somebody says, "Oh yeah, doc, I'm 2 hours away from the hospital," is probably not the best person to say, "Well, here you go, take a medicine and come back," right? So what is the medical management in general? Okay, in general, it is misoprostol of some sort plus mifeprostone. And usually the mifeprostone is given 24 hours before the misoprostol. Now, sometimes and I can tell you, the mifeprostone is not readily available everywhere. So 800 micrograms of vaginal misoprostol is good. Now, every time I've given this lecture, people confuse and say, I can't do medical management after 70 days or after 60 days. That is correct if you are trying to terminate the pregnancy and there is a heartbeat. If there is no heartbeat, then medical management can be done, right? With the knowledge that it's much more effective till about 13 weeks of pregnancy. And then after that, a D&E becomes the most preferred option, provided that you have somebody in your institution or hospital that is well versed and well trained in doing second trimester D&Es. Right now, once you, of course, with a demise, you hit 28 weeks, then the management is going to be the same as the management of any laboring patient or any non, perfect. So after you do the D&C, a lot of people do the D&C under ultrasound guidance. So you have the ability to, after your D&C, make sure that your uterine lining is thin. The other option is to actually follow your serial beta HCGs and make sure that they go back to normal. I personally just, when I do my D&Cs, I've got an ultrasound, I scan. If I don't see anything in the uterus, I'm pretty much done with that patient unless she comes in and has a complaint. How many of you follow your patients with serial beta HCGs versus an ultrasound? Anybody do serial beta HCGs after a D&C? All right. Perfect. Now, if it's medical management, then of course an ultrasound is definitely, so you need to definitely make sure that everything is evacuated, or alternatively you can do beta HCGs. Okay. Surgical management is recommended and preferred. Okay, I don't 100% agree with that statement, but that is coming from ACOG. I think it is not recommended and preferred. It is based on your patient situation, what they like and what they don't like, because it is still, D&C is surgery, right? And there are certain people out there that do prefer to avoid surgeries. You can perforate, you can cause an infection. Now, okay, but it is definitely for hemorrhaging patients, hemodynamic stability, infection, anemia, bleeding. All right, some people will say if you have severe cardiovascular disease, you don't want to compromise them and treat them, and those desiring immediate treatment. Okay, suction and curettage is the recommended method. You can use, you can't use a sharp curette, and you can perform it as an outpatient procedure. Remember, doxycycline is recommended, and you've got to give them RhoGAM if they are Rh negative. Okay, perfect. Any questions so far? Any questions so far? All right, perfect. So here is what I'm going to say. Somebody comes in and says, "Doc, I've had 4 miscarriages. All right. I am really tired. I am really tired of these miscarriages, and I don't want to have them anymore. What is causing all of this? What should be your answer, and what can you tell this patient?" Right? What would be your answer, and what do you tell this patient now? Anybody wants to say, all right, she's your patient, she comes in, she's fed up, she's anxious, and she wants answers, right? So how can we provide her answers? So when I look at my patients and they come in with things like this, I always usually tell them, I say, look, a good pregnancy, 2 years, 3 years, 4 years, 5 years, 6 years, 7 years, 8 years, 9 years, 10 years, 11 years, 12 years, 13 years, 14 years, 15 years, 16 years, 17 years, 18 years, 19 years, 20 years, 21 years, 22 years, 23 years, 24 years, 25 years, 26 years, 27 years, 28 years, 29 years, 30 years, 31 years, 32 years, 33 years, 34 years, 35 years, 36 years, 37 years, 38 years, 39 years, 40 years, 41 years, 42 years, 43 years, 44 years, 45 years, 46 years, 47 years, 48 years, 49 years, 50 years, 51 years, 52 years, 53 years, 54 years, 55 years, 56 years, 57 years, 58 years, 59 years, 60 years, is like building a house. So you need good foundations. And for me, the first thing that you look at is, do you have any major risk factors that can contribute to you getting miscarriages multiple times? Are you a diabetic that is not well controlled? Do you have thyroid disease that is not well controlled? Are you hypertensive, right? Versus are you at the upper end of the spectrum where all of your 4 miscarriages between the age of 39 and 41? Okay. And if right, we need to have our foundations be solid, what are some of the risk factors you have that are modifiable that we can fix? But then after that, you go through them and you say, well, here are the causes of miscarriage. Number 1, there is aneuploidy, right? That's one of the causes. Number 2, there's that antiphospholipid syndrome, especially if you've had more than 3 miscarriages before 10 weeks, or you've had a heartbeat loss after 10 weeks. Now, is the uterus normal? Do you have an abnormality in your uterus, fibroids, right? Septum. Is there anything that is, anatomically causing these miscarriages? 4, right? Do we have parents that are carriers of a translocation that puts this baby at an increased risk of having multiple Down syndromes and things like that? I guess these are all reasonable questions. Now that I've gone through this, anybody can think of anything else that they would want to add? I would like anybody to participate, right? Because this is kind of a real life scenario, right? Very possible that you get somebody with this type of scenario. What else do you guys look for? Anything that I'm missing that I didn't talk about that you guys want to add? Anybody has any additional comments? Okay. So it is defined as 3 or more spontaneous abortions before 20 weeks. Now, 1 miscarriage does not warrant workup. Okay, 2nd miscarriage doesn't warrant workup usually, but if the patient is very anxious or she's on the older side, you may want to do workup after it, because some people's definition of recurrent is more than 2. However, having said that, the definition at this point that is most commonly used and used in ACOG, used in antiphospholipid syndrome diagnosis, is 3 or more spontaneous abortions before 20 weeks, right? 75% though of people with unexplained recurrent fetal loss will still achieve pregnancy, right? So if you think of the miscarriage rate as being, roughly about 15 to 20%, okay, depending on who you read, but these are like 15 to 20% of documented pregnancies, then the rate for these patients to achieve a normal pregnancy after three consecutive miscarriages is high, as long as we could not find a reason. All right? Perfect. Moving forward, what is my workup? I can offer maternal and paternal karyotype. If I have the availability and the patient comes in while she is pregnant, we can send the baby for fetal karyotype, because if the baby constantly shows trisomy 21, then I may want to look for a Robertsonian translocation in the mom. You've got to make sure that her thyroid function is good, diabetes is fine, high blood pressure is controlled, and prolactin. Then I've got to look for antiphospholipid antibodies. Assessment of the uterus. Thrombophilia workup is not generally recommended unless there is a history of clots and thrombosis and all the other potential indications for thrombophilia workup. What is antiphospholipid syndrome? So when I want you guys to kind of tell me, the minute I say antiphospholipid syndrome, what are some of the things that come to your mind? I need people to type in the chat box. I need to make sure that my doctors here out there are with me. So what comes to mind when you guys, lupus, anticoagulant, excellent, what else? So I'm gonna kind of go through kind of a yes, no, right? So that if you say yes, you agree with me or you don't. When I say antiphospholipid syndrome, I think of increased risk of adverse pregnancy outcomes. Is that a fair statement? Yes, right? If I say antiphospholipid syndrome is diagnosed clinically and through lab criteria, is that a fair statement? It is, right? If I say that for me to diagnose antiphospholipid syndrome, it is not enough to have the lab criteria performed once and be abnormal, but I've got to perform it more than once, and I've got to give 12 weeks in between those labs. Can be associated with blood clots. True, right? Can be a cause of recurrent miscarriages and IUFD. True. Can be associated with bad obstetrical outcomes as a whole, such as early onset preeclampsia with severe features, IUGR. Excellent. So these are all things that come to mind. And then remember, the labs that you can do for it are 3 different labs, right? 3 different labs. And we'll talk about them in a minute. Excellent. So antiphospholipid syndrome, it is an autoimmune disorder. It's a presence of characteristic clinical features and specific levels of circulating antiphospholipid antibodies. The diagnosis requires 1 clinical and 1 laboratory. So you don't need all 3 of them, and you don't need all the clinical criteria. So the labs that you look for are 3: lupus anticoagulant, anticardiolipin antibody, and beta-2 glycoprotein. Now, whenever I do a consult as a maternal fetal medicine, I actually have a tab right now where I actually don't just say antiphospholipid syndrome workup. I try and help my colleagues, and I actually put these down: lupus anticoagulant, anticardiolipin antibody, and beta-2 glycoprotein. Now, lupus is either present or absent. Anticardiolipin antibody is usually greater than 40 GPLs or greater than the 99th percentile, depending on the lab. And then immunoglobulin, the beta-2 glycoprotein, remember, we look for either the immunoglobulin G or the immunoglobulin M isotypes. No other isotypes, just the IgG and the IgM, right? And we look for a titer of greater than the 99th percentile for a normal population. Then here are some of your clinical criteria: vascular thrombosis, okay, pregnancy morbidity, IUFD after 10 weeks of a morphologically normal baby, all right? 34-week gestation because of eclampsia, severe preeclampsia, or features consistent with placental insufficiency equals, for instance, FGR. Now, this is a little bit controversial. If you actually read the practice bulletin, right, they tell you that this, when you have severe preeclampsia, may not necessarily be one of the diagnostic criteria, but it is recommended to do it when you have those adverse pregnancy outcomes. 3 miscarriages. Now, in unexplained pregnancy loss, there really is not a treatment for it. But if you have pregnancy loss and antiphospholipid syndrome, then what potentially could be something that you should give these patients in their next pregnancy? What should you give them in their next pregnancy? Okay. What about, yes, Lovenox, right? So what I want you guys to also remember is aspirin right now, there is a committee opinion that actually tells you the indications of giving aspirin. And I see a lot of now consults that are coming my way where a lot of people have forgotten to give the aspirin when it's indicated. So for example, a lot of people forget to give aspirin in diabetics. Every diabetic who gets pregnant has an increased risk of having preeclampsia, so she should be on aspirin, right? People that have autoimmune diseases such as SLE should also be on aspirin. Renal disease on aspirin. Basically, anybody that has an increased risk of getting preeclampsia should be on aspirin. Some patients some conditions it requires one, and then there are some other conditions that require to have more than one. So, for example, obesity and AMA, if they happen together, that's an indication for aspirin. Are you guys well aware and well versed of the indications for aspirin? You guys know them all and give them to your patients? All right, if not, we can review it in our last review session. I think it's worth it. I do have a slide in my review session on Wednesday where I go through indications of aspirin. And I think one of the things that is very, very important for a lot of for a lot of us to know is right now timing of delivery. And recently, the American College of Obstetrics and Gynecology came up with a list of late term and late preterm, early term indications of delivery. They put an extensive list, and after I thought I knew it and memorized it, they went ahead and just released a new summary with conditions that were not there. So, for example, right, they actually now tell you that a history of IUGR in a previous pregnancy is an indication for you to put them in testing. Di twins, which was previously not an indication for testing, is an indication for testing. All right, perfect. So interestingly, antiphospholipid syndrome has other complications that we don't necessarily listen to or know about, okay? So our normal obstetrical complications are fetal and recurrent pregnancy list, IUGR, and preeclampsia. Now, IUGR, by the way, the new terminology for it is FGR, okay? But I don't foresee people stopping using the IUGR for some time. We know about the increased risk of venous embolism, right? Or, and then stroke, thrombocytopenia, livedo reticularis, cutaneous ulcers, choriogravidarum, and all of these are potential complications that can happen in with antiphospholipid syndrome. Okay? These are the indications. Woman with a prior unexplained arterial or venous thromboembolism, new arterial or venous thromboembolism during pregnancy. And by the way, antiphospholipid syndrome is not affected with pregnancy. So a positive in pregnancy is still as believable as a positive outside of pregnancy. Then if you have 3 or more recurrent embryonic or fetal losses, early preeclampsia, like I said, there's no consensus, although it is part of the diagnostic criteria. So it's very interesting. Okay, management, we said, right? These patients should get prophylactic doses of anticoagulation, whether it's heparin or Lovenox, and low-dose aspirin during pregnancy, and this should be continued for at least 6 weeks postpartum. Okay? Same applies if you've had a thrombotic event. Now, occasionally there will be patients that will be tested for the antiphospholipid syndrome. You're going to look at them and say, why did they test you? What made them test you? What not? And so forth. And they'll say, well, I had a distant cousin that had this or had that. And in just antiphospholipid syndrome with no adverse outcome, there isn't really, there is not a lot of studies to guide it. So it's guided by expert consensus. And they tell you that you can do either clinical surveillance or prophylactic heparin whilst the patient is still pregnant. And then they advise to put them on anticoagulation postpartum. All right. Cerclage, okay? So when we look at cerclage, there is history indicated, physical exam indicated, and ultrasound indicated. So history indicated, what does that mean? It's somebody who comes in, right, who has had, a painless dilation of the cervix that occurred at 16 weeks with no bleeding, no cramping, none of that sort of stuff. So then she comes in and she's pregnant again. That would be somebody who her history suggests she should be on cerclage. And then you do this somewhere at 12 to 13 weeks. So this is a history in a prior pregnancy. And because of her history in a prior pregnancy, I'm going to put a cerclage for her now. Physical exam indicated is somebody who comes in for a prenatal visit at, let's say, 18 weeks. She's asymptomatic. She says, I'm having increased discharges. You go ahead and you do a speculum to take a swab, and you're like, oh, your cervix is 2 centimeters dilated. However, you don't have any pain, you don't, and that would be an indication. Ultrasound indicated would be somebody who has a prior preterm birth, and you're doing serial cervical lengths from 16 to 24 weeks, which is the time that you're supposed to do cervical lengths. And she comes in, let's say, at 18 weeks, and you measure her cervix, and it is less than 2.5 centimeters, right? That would be a ultrasound indicated, which is somebody who's had a prior preterm birth, and now in her subsequent pregnancy, her cervix is less than 2.5 centimeters. All right. So this is just a description of what we just talked about. Now, why do we not place it earlier? Because this allows the occurrence of the spontaneous abortions or miscarriages that are going to happen because of aneuploidy, abnormal pregnancies, and so forth. And the reason why it's reasonable to do it at 13 to 14 weeks is that is still before the pregnancy actually has time to push on the cervix and push the pregnancy out. So if you think it's a weak cervix, putting it at 13 to 14 weeks is very, very reasonable. It also gives you an opportunity to do screening tests to make sure that the nuchal translucency is good. If you opt to go for an NIPT, you make sure that that is normal as well before you commit the patient to keeping that baby in by doing a procedure. Okay. History indicated, okay, is given if the patient has a history of 1 or more second trimester pregnancy losses, painless, no contractions, and no evidence of infection. Now, also, if she's had cerclages in prior pregnancies and they worked because of a pregnancy like this, and then they come in for subsequent pregnancies, then the general rule is if you've chosen a patient well and you've put a cerclage in a well-chosen patient, then subsequent pregnancies, they should get cerclages. Okay. Exam indicated, it's called the rescue cerclage. It's placed emergently. Of course, it is more risky than scheduling somebody to get a scheduled cerclage. And it's offered to women who present with cervical dilation in the absence of contractions or evidence of intraamniotic infection. I want to stress all of these are only done up to 24 weeks. Any questions so far? Everything is clear? Any questions? All right. I hope you guys are still enjoying the lecture, because I am. And believe it or not, we've almost been doing this for 50 minutes. I don't know where time flew. All right. Okay, perfect. Let's move on. So complications of cerclage, of course, you've got cerclage failure, you've got infection, you've got PPROM, which is ironic because that's exactly what you're trying to prevent, right? Cervical lacerations, bleeding, and miscarriages. The recurrent pregnancy losses, if an etiology is identified, treat the cause when applicable. If unexplained recurrent fetal loss, there is no therapy or proven benefit to giving aspirin and heparin unless you're giving the aspirin for preeclampsia mitigation. We're going to wrap up this hour by talking about IUFD. So what is the definition of IUFD? It is a fetus showing no signs of life as indicated by the absence of breathing, heartbeat, pulsation of the umbilical cord, or definite movements of voluntary muscles. Now, generally the consensus is if this happens after 20 weeks, then that is considered an IUFD. In somebody who does not have dating or has very poor dating, then it is a weight of more than 350 grams. The reason they chose the 350 grams is because that corresponds to the 50th percentile of weight at 20 weeks. Okay. Thankfully, the stillbirth rate in the United States is not high. Okay. It is 5 or almost 6 per 1,000, right? Early stillbirth is 3.1 in a thousand, and late preterm birth is approximately 2.9 per 1,000 births. Okay. So when we have somebody who comes in with an unexplained stillbirth, there's going to be two things here, right? First of all, you've got to get to the consensus that this is unexplained. So when the IFD happens, there's a slew of investigations that you're supposed to offer to the mom. And then if you couldn't find a reason, what do you do in subsequent pregnancies? And then if the mom tells you, is this high likely to happen or is it low likely to happen? You tell her it is still very, very low, because the recurrence of stillbirth after 20 weeks is estimated to be about 7 to 10 per 1,000. Okay, with the most of this risk occurring before 37 weeks of gestation. The risk of recurrence of a stillbirth after 37 weeks is very low at 1.8. But does that mean that this pregnancy is going to be left alone and we're not going to do anything to make sure that this pregnancy is managed differently? No, we're going to do a few things differently in the subsequent pregnancy. Now, if the patient has poor obstetrical history like diabetes and hypertension, then the rates could potentially go up. Risk factors, same culprits, right? Hypertension, diabetes, somebody who had a complicated birth, shoulder dystocia can cause IUFD, maternal diseases, infection, right? If somebody got intraamniotic infection, or if you actually had undiagnosed herpes, the baby could potentially, have all sorts of issues and things like that. Going post-term and post-dates, maternal obesity and AMA, which is why the guidelines now tell you for AMA and obese patients, they should also be enrolled in antepartum testing. Risk factors to continue. We talked about antiphospholipid syndrome, trauma and uterine rupture, drugs, smoking, cholestasis of pregnancy. And unfortunately, what is the biggest problem with cholestasis of pregnancy is the IUFD is sudden, right? So just as a general rule of thumb, most of the time when I tell you something carries an increased risk of IUFD, it will generally also mean that you're going to enroll patients in antenatal testing towards the end of pregnancy. Ironically, being a male, okay, increases your chance of having an IUFD, and in African Americans, it's more likely to also happen. Okay, baby has chromosomal abnormalities, more likely to have IUFD. If the baby has an AV canal or has abnormal kidneys or has an abnormal heart, then it's also more likely to undergo an IUFD. If the baby is not growing well, FGR, more likely to have IUFD. Infections, multiple pregnancy, placenta previa. And then do you guys know what hydrops is? Everybody's fully aware of what hydrops is? What is hydrops? Okay. So hydrops, okay, hydrops is the presence of extra fluid in the baby, right? It's accumulation of fluid in the baby. And to be more specific, it is the presence of fluid in 2 or more compartments. So pleural effusion with ascites is enough. And then, believe it or not, polyhydramnios is one of these criteria. And some people even add placentomegaly, right? So if you have placentomegaly with pleural effusion, that's enough to call it hydrops. Okay, so what is the workup? You've got to do a complete history and physical exam. You've got to test for antiphospholipid syndrome. You've got to look for parvovirus, screen for syphilis, TSH, CBC, and a KB stain. Now, those are all things that you've got to do for the patient. If now severe placental pathology is suspected or in the presence of IUGR with a family or personal history of thrombosis, you may add factor V Leiding, prothrombin mutation, antithrombin 3, MTHFR, and protein C. Okay. So this is the fetal workup. Inspect the fetus and the placenta. Right? You need to get a weight, head circumference, and length of the fetus, weight of the placenta, photographs of the fetus and the placenta, right? And you've got to get frontal, profile, whole body, extremities. And if you see any abnormal findings, then you've got to document those. You've got to talk to them about cytogenetic specimens. And the way that you can get the cytogenetic specimens could be through the amniotic fluid, right? The placenta, the umbilical cord, or through fetal tissue. And the highest yield out of all of these is also, or one of the highest yield things is the fetal autopsy. Okay, this is a nice little table that just tells you the stillbirth, right? And what to do based on things like that. So if you've got, for example, a known anomaly, right? Then you really shouldn't look for antiphospholipid syndrome and KB stain. The one that's going to lead more is the genetic analysis, the genetic testing, and of course the autopsy and placental pathology. All right. We wrap up this little hour by talking about what do you do in subsequent pregnancies. We said pregnancy is like a foundation. So you've got to optimize modifiable factors. If she's diabetic, you control her diabetes. Hypertension, you control her hypertension. She's got antiphospholipid syndrome, you mitigate risks by giving the history. Obtaining accurate dating, because what's to say that this baby died because it was post dates and we should have delivered it early. You offer them aneuploidy screening, right? Whether it's the NIPT, you also offer them diagnostic tests if they want. You do a fetal anatomic survey between 18 to 22 weeks, growth scans, and you put them in antenatal testing, right? And usually no later than 32 weeks or 1 to 2 weeks prior to the IUFD that occurred in the prior pregnancy. And fetal kick count precautions, you've got to give them support and reassurances. Now, those of you that have read the recent IUFD practice bulletin, before it was a hard stop, you need to deliver it. So first of all, it was delivered at 39 weeks earlier with amniocentesis, right? Now everybody's shying away from amniocentesis for fetal lung maturity. They tell you if the delivery is indicated, you do not need amniocentesis reassurances. So you counsel them. And if they are really anxious, they're really worried, it is acceptable to deliver them as early as 37 weeks, right? And this is in ACOG's publication, so your hospital committees should not give you any grief with that. Okay, these are multiple choice questions, but we did go through them, right? Does anybody know the answer to this one? Let's see how many of you looked at this while we were doing the lecture. So in a poorly dated pregnancy where the gestational age is unknown and there is a loss of fetal heartbeat, what is the fetal weight what the pregnancy is considered to be an IUFD? Answers? Anybody wants to answer? Okay. Remember, it was what corresponds to the 50th percentile at 20 weeks. 50th percentile at 20 weeks. And this was 350 grams. All right. What about this question? This question is easy and nice. Which of the following is part of the antiphospholipid syndrome workup? Anybody wants to volunteer? Yeah, absolutely. C. Okay, so before we move to multifetal gestation, do you guys want a 5-minute break or do you want us to just go to multifetal gestation? Go on? Everybody wants to go on and then we break at 10 o'clock? Okay, sounds good. Now, honestly, did you guys enjoy the last lecture and felt it was nice for you guys? Well, if you felt this one was nice, guess what? The twins is even going to be nicer. It's one of my favorite topics. And actually, I'm very excited because recently or a couple of days ago, we had somebody that came in with triplets, and my sonographer got one of the most beautiful images of an epsilon sign, and I was very excited. And of course, I'm a nerd, so I've got my flash drive, which every time I see some interesting pictures on ultrasound, I go put my USB, download them, and play with it and stuff. So she walked into the room. She's like, "Look what I've got for you." And I'm like, "Oh yeah, I'm very excited." Aren't we nerds as doctors? We get excited about stuff that nobody else ever gets excited about, right? All right, sounds good.